The carbon dioxide partial pressure in ventilated patients is commonly monitored in ICU. There are two main methods for detecting carbon dioxide in the expired air of a ventilated patient. Calorimetric capnography relies on the fact that carbon dioxide is an acid. Moist air containing carbon dioxide will thus turn litmus paper yellow. Commercially available devices can be inserted into a circuit and can semi-quantify the amount of carbon dioxide released. Alternatively, infrared absorbance can be used. This is based on the characteristic infrared light absorbance of CO2 gas. Other methods such as mass spectroscopy, Raman spectroscopy, and photoacoustic spectroscopy are occasionally used but are far less common. Two main configurations for gas sampling are available: inline monitoring and side stream monitoring. In the former, the expired gas all flows through the detector, while in the latter, small amounts of the expired air, usually around 100 mL per minute, is diverted through the detector. The disadvantages of the former is that it causes a higher resistant load for the patient, can only be used in a closed system, increases dead space, and is bulky. However, it is more reliable and responsive to change than the side stream form, which can easily become obstructed with secretions after prolonged use. The waveform generated by continuous electronic modes has a distinctive shape. The diagram illustrates the described phases of the waveform. During inspiration, the measured CO2 is almost zero, reflecting ambient air CO2 concentrations. At the start of expiration, CO2 initially does not rise as dead space starts to clear. With further expiration, mixing of dead space and alveolar air occurs and CO2 rises. Finally, with all dead space cleared, the CO2 measured plateaus and is thought to reflect alveolar CO2 concentration. This is known as the end tidal carbon dioxide. A secondary goal of end tidal CO2 monitoring is to monitor non-invasively the patient's arterial partial pressure of CO2. In practice, there is always a gap between arterial and end tidal CO2 levels due to the physiological dead space and shunt. In health, this gap is usually no more than 1 to 2 millimetres of mercury. Mechanical ventilation, and in particular for critically ill patients, the relationship between arterial and end tidal values becomes more tenuous due to changes in perfusion and dead space. False positive capnography in the intubation setting have been reported in association with prior consumption of fizzy drinks, though sustained waveforms and values do not occur. Occasionally, cardiac oscillations may be seen influencing the waveform. Infrared capnography is influenced by water vapour, and a moisture exchange filter should be placed between the capnography sensor and the patient where possible. Nitrous oxide also interferes with measurement, but this is rarely used in the critical care environment. The primary function of continuous capnography is the detection of disconnection of the circuit. This, along with changes in the circuit pressures detected by the ventilator, is the most immediate and sensitive indicator of disconnection. Many critical care societies recommend that capnography waveforms and alarms be present for all mechanically ventilated patients. Capnography is also a standard method to confirm successful intubation in the trachea. The clinical importance of absolute value of end tidal CO2 is debatable, but a trend or sudden change can be highly significant. Because CO2 excretion from the lungs relies on the pulmonary perfusion, a sudden reduction in end tidal CO2 can indicate a low perfusion state. This can be seen in massive pulmonary embolus or in cardiogenic shock, or may result from an accidental migration of the tube into a bronchus. By extension, CO2 monitoring can also be used to detect return of spontaneous cardiac output or even measure the efficacy of delivered cardiac compressions. A slowly increasing end-tidal CO2 can indicate that ventilation has become impaired and can spark a search for the offending cause. The shape of the Capnograph waveform can also provide information. As mentioned previously, there should be rapid clearing of the physiological dead space, resulting in a steep uprise and clearly defined shoulder, leading to a plateau. In cases where small airway flow is restricted, attainment of the plateau can be delayed or even absent. In controlled modes, dips in the capnograph trace during expiration may indicate that the patient is attempting to breathe. These are sometimes known as curare dips. Failure of the end-tidal CO2 to return to zero suggests that rebreathing is occurring. This is due to a ventilator fault, partial tube occlusion, or inappropriate settings. Comparison of the end-tidal CO2 to PaO2 gradient can indicate the presence of changes in dead space or VQ mismatching. However, this is a relatively non-specific indicator.